So one of the key limitations in treating these patients is lack of data or lack of evidence in one device versus the other device. And we understand that the trial in these population is very, very difficult. Patients are very sick. Getting consent and implementing those therapies is very, very difficult, and trial is very difficult. So how do you suggest that this field can be taken forward in terms of more data and more evidence?
These patients are very tough and very sick. And as I already said, limited communication at the same time, including their families perhaps even absent. So how do we even get to enroll or consider them for a clinical trial? No wonder the studies in this area have been small, and at the same time, because the classification didn't exist, there was a mixed bag of patients. Some of them included many people more at risk with lower event rates, and some of them included all the way the other end, people in extremis that perhaps were kind of bordering for a more appropriate for palliative care as opposed to true medical intervention. So by utilizing the shock team and the SKY classification to understand where we are and what kind of people really we want to enter, then we have to see how we can move, and we're already moving in the United States for a registry, a shock registry. And every country and every region could also move in this direction. And once we reach that level, then we could help study, if you want to say, design as well as implementation through the registry that could already have given the regions a comfort level and, if you want to say, a pathway through which they collect basic demographic and other basic, very simple, not too many, critical data of the patients for the registry anyhow, for the clinical use anyhow. No different than that. But at least the mentality of understanding what kind of patients we're treating, that's going to be like very facile.